Bismillahirrahmanirrahim. Assalamu alaikum and good morning to all my senior colleagues and teachers. So today we are here at this venue of PC Bhurban to discuss the role of CT angiography in coronary artery disease. I think all of you know me. I'm Dr. Tahira and recently promoted as wing commander. I'm working at BF Hospital, Islamabad.
58
And this is
You
my
have a 58
hospital where I work.
58
And the other picture, this is of my cath lab. And we are very infant setup. We have recently started doing cath there for the last 2 years. And let me tell you that during these journey of 2 years of independent cath lab at PF, that was the main era of COVID. So I have experienced CT angiography as a very important diagnostic tool in that difficult era. We all know that it's a very non-invasive technique and it can help us in visualization of coronaries through IV contrast. So basically it's a gatekeeper for me to invasive procedures and it's a very high negative predictive value test. It correlates up to from 90 to 95% to invasive coronary angiography. And it's a very wonderful tool for exclusion of coronary artery disease in patients whom you think that there is very low or moderate probability of disease. Whenever you get stuck and you get equivocal stress image, again you can use the help of CT angio. And for suspected coronary anomalies, when you could not find RCA or you think it's anomalous region, again you can take its help. In acute atypical chest pain specifically, I would like to mention that in COVID, when you cannot take every patient to cath lab, in that era it really helped us. It also has got some limitations. When your patient is having atrial fibrillation or rapid heart rate, or the calcium score is high, previously a lot of stents are there, or the CKD patients, the vessel size, if the vessel size is smaller in obese females and cooperative patients, again it has its limitation. And remember that radiation exposure in CT angio is more as compared to a conventional angiogram. So I would divide my presentation in 3 steps. Role of CT angio in detection and prognosis of disease and its role in ACS and in already established stable coronary artery disease. So as I mentioned that this test is having very high negative predictive value. A recent article I was reading in August 22 paper from American Heart Journal of Preventive Cardiology. With the new machines, its predictive value has gone up to 99%. And if you are using this tool in your triage, you can divide your patient and easily decide whether this patient needs invasive angiography or not. So it helps in preventing the unnecessary invasive testing and it can risk stratify your patients. So the calcium score is more than 100, you can still say that patient is having medium risk. And if the score is more than 400, then patient is having high risk. And above 1000, patient is definitely having high risk. And even in the short term, in the next 1 to 2 year, is definitely there. So it's very good diagnostic tool for coronary artery anomalies. Here you can see that RCA is originating from left sinus and you may get difficulty in engaging your catheter, but on CT angio you can easily see that. So another helping point of CT angio is that you can evaluate your plaque, whether it's calcific or it is soft. And we all know that composition of plaque, it is the basic thing which determines the risk of rupture. High risk plaques can be seen, they have thin fibrous cap and they tend to rupture more, they tend to more cause MI. Now going towards the second part of my presentation is its role the triple rule out strategy. These are the patients who are having severe chest pain and you don't find any ECG change, and still the ACS is in your differential list. Aortic dissection is one of such cases. Very important differential diagnosis and very easily picked up on CT angio. Then pulmonary embolism. As I mentioned earlier that in COVID it really helped. This is one of the image of a patient who presented with chest pain and nobody was suspecting that we will find this pulmonary embolism. In some cases where circumflex do not give you the ECG changes, maybe the troponins are not traced, but you find such a plaque in the circumflex and telling you that yes, it's ACS. Coronary artery disease evaluation is also very reliable upon the CT, and here you can see that this LED is having very high calcium. In RCA you can see the spotty calcification. So the coronary artery stenosis is almost close to the conventional angiography, and you can see whether the disease is mild, moderate or severe, or the artery is totally occluded on the CT angio. Here are some examples. You can see that the CT has shown that this LED is having critical stenosis 90%, and same thing was seen on the angiography. Another important part of CT angio is post-operative evaluation of coronary artery in the cases of bypass for seeing the patency or the occlusion of graft. CT is very helpful. These are some beautiful images of immediate post-CABG patients. Here you can see Lima and the SVG to OM, SVG to diagonal, and all are patent. I remember one of very interesting General Sohail's statement. I wish sir was here. Sir हमेशा कहते थे कि स्टेंट डालने से पहले पेशेंट शेयर होता है और स्टेंट डालने के बाद मरीज मज़ीद शेयर हो जाता है. तो एक वो पेशेंट जिसको आपने स्टेंट डाल दिया है हमेशा चेस्ट पेन के साथ आएगा, एंड इन सच पेशेंट्स द डायग्नोस्टिक टूल ऑफ CT angio is really helpful. Here you can see if you use the MPR images, you can even see that this is the marginal branch taking off and your stent is patent. In cases of stent thrombosis or subacute thrombosis, you can see that there is a soft plaque or thrombus inside the stent. ISR or stent restenosis, it is again easily picked up by CT angio. Coronary stent fracture is rare, but its incidence is 1.7 to it may be up to 29%, specifically in aggressive operators where you use a lot of NC balloons, you can cause the stent fracture. So a new technique is the correlation with FFR. This function is available in new machines and it's really going to help. Those lesions which seems to be 60% or moderate-ish kind of lesion, CT can provide you FFR, and it really correlates with your conventional angiography and FFR. So I hope that this function gets available soon in every lab of us. So that was all for today. Thank you. Any question? Yes, please. I mentioned previously that the cutoff generally is considered to be 400. If it's below 400, you can always stop the next invention. But it again depends on you. Believe me that there are some patients, if the patient comes again and again with chest pains, sometimes we go for the next test.
इसकी जो establish वो है कि some people do for even more than 1000, but to interpret that is a problem. There is no contraindication, but it's better to just perform the calcium score. Which is high calcium score, it is in the form of a ring, then it is in trouble. But it is a streak outside, then you don't have anything, something.